Okay, thank you everyone for joining us for this webinar, introducing the National Centre for Social Prescribing Data and Analysis. So we'll go over the housekeeping rules now. I think we've got joining us. Go to the next slide. Okay, thank you. So we are recording this webinar, so after the webinar is finished, we'll send you the slides and a link to the recording as well, and also they'll be on our NASP website, so you can access them in your own time. If you have any questions, please submit them via the Q&A function, so that's at the bottom of the screen, and then at the end of the presentation, so we'll have about 10-15 minutes, where we'll have the Q&A session where I'll read out some of those questions to the panel. You can also use the chat function at the bottom of the screen as well for introducing yourself and for networking. And if there's any technical issues, raise these in the chat and a member of the NASP team will help. And there's also closed captions available and turn these on the bottom of your screen. So hopefully that's clear. So I'm Gerald Bradley. I'll be chairing this webinar. I'm the Deputy Director for Evidence and Impact at NASP. First of all, we'll hear from Charlotte, who's our CEO at NASP. She'll give an overview of the data and the context for the development of the National Centre, and then Daisy will provide an update of the last 6 months of the National Centre for Social Prescribing Data Analysis. So thank you, everyone. Over to Charlotte.
Hi, everybody. Thank you so much, Gerald. I hope you can hear me okay. I'm going to share my slides, so if you bear with me one moment. There we are. Excellent. So I'm Charlotte Osborne-Ford. I'm the Chief Executive here at the National Academy for Social Prescribing. And I'm going to do a brief overview of the National Centre for Data and Analysis, why it's important, and what we're aiming to achieve. So most of you should know that the National Academy for Social Prescribing, we're a charity, but we're currently commissioned by government to advance the scale and spread of social prescribing. And we have 5 core functions around ensuring that social prescribing grows in an evidence-based way across England, and particularly focused on addressing inequalities. And today you will hear mostly about evidence, because that is one of our most important functions, but it's really key to the wider work we do, which is also around connecting up the system, strengthening, supporting and providing education and training for the workforce, identifying and scaling innovation, leading and driving investment into social prescribing, particularly into community interventions, and raising awareness. So you should know what social prescribing is, but as it was only formally defined 2 years ago, we always highlight that social prescribing is actually a process. And what it means is somebody in the community or in a clinical setting identifying that somebody has health-related social needs and working with them to co-produce a prescription, a non-clinical prescription, to improve their health and well-being, and then linking them in to services and support in the community. And that could include an incredibly broad range of services, support and community groups. So there really is no typical social prescription. People will be linked and connected to a hugely diverse range of things. We have over 168,000 charities in the UK, and many more charitable and community groups, and lots of other non-charitable statutory and public services. Link workers and others that do social prescribing will really try to identify what is most important to the patient or person, navigate everything that might be available in a local area, and to connect them in. So in England, social prescribing became part of the NHS GP contract back in 2019, with funding to employ social prescribing link workers. And since then, we've seen huge progress. We now have over 3,000 link workers employed in GP GP practices and many more employed in the wider community and in other public health services. And as Daisy will tell us, we've now got some really excellent data which shows that the scale of social prescribing in England, that at least 9.4 million GP consultations included social prescribing. And our own data at the National Academy shows that now at least 22% of the public in England know what the term means and value social prescribing. So we expect social prescribing to only continue to scale and grow and to become more important. Many of you will have seen the NHS 10-year plan, which was published in the summer. And this has 3 important shifts: from hospital to community, from sickness to prevention, and analog to digital. Social prescribing is a really important way that we can help make those shifts. And there are some really specific commitments within the 10-year plan which are relevant to social prescribing, such as expanding neighbourhood teams and also making sure that patients with complex needs have a holistic care and support plan, which is that important function of link workers. So we are likely to see social prescribing grow, and if and when that does happen, we need the very best data and evidence to drive that growth and to make sure social prescribing is reaching the right people. So alongside that, the policy drivers, we're also seeing huge media interest in social prescribing at the moment. This is a summary of just some of the national media that has been published online and in print and on the television and other media channels over the last few months. And you'll see from the sort of tone and the quality of this, it's often about patients sharing their own experience, their own stories of how social prescribing is making a huge difference to them. And I think the more that patients and GPs and others share their stories of social prescribing and talk about how it's really important for the future of the NHS, again, we're likely to see more interest in social prescribing, more investment in social prescribing, and greater scaling and rolling out within the NHS. So we really need to know who is accessing social prescribing and how are they accessing it? Is it just through GP practices, or actually is it more in the community? Is it in other parts of the public health system? And what is the impact on the person? What is the health impact? What is the impact on their well-being, their life satisfaction, their ability to manage their health and their own medical conditions? We need to understand what is the impact on the NHS and the health and care system, and of course the impact on the wider voluntary community, faith and social sector. Are they able to work in partnership with the NHS and to support more patients in a meaningful way? And of course, is it value for money, especially when compared with other NHS initiatives? And so a lot of what we do at the Academy is gathering evidence from case studies and patient stories all the way up to academic research to make sure that there is the best possible picture of what social prescribing is achieving. Some of the most recent research and evaluation has been focused particularly on that element of, does social prescribing save money? Is it cost effective? Because we know in order for further investment to go into social prescribing, both link workers and into a wider community, activities, groups and services, that we need to understand what is the impact on the health system. And NASP published this report last year, which was the summary of evaluations within the health service about the impact of social prescribing. And what we see in this report, we looked at 9 different areas in England, and we asked those NHS systems, what data do they have that shows that people accessing social prescribing are less likely to need particularly avoidable care? So A&E attendances, unplanned hospital admissions, GP appointments. And you'll see from this summary that there were many very good examples of evidence that social prescribing is reducing demand. So this isn't academic research, it's a summary of evaluations, but often very robust evaluations, including some with various forms of matched control. And as part of that, we've analysed all of the different bits of research, evaluations and studies which look particularly at social prescribing and NHS demand and whether there are cost savings. And we published this blog earlier this year, which looks at our work to collate this research and to draw conclusions, particularly for commissioners and NHS managers who may want to invest in social prescribing, but need assurance that social prescribing is cost effective. And what we see when we looked at 19 different studies, which were involved over 42,000 patients, is that there is some really robust evidence that social prescribing has very significant return on investment. And we're continuing to use these sorts of studies to advocate for social prescribing to be part of medical care. Alongside that, some other really important research that was published this year, which was funded by the National Institute for Health and Care Research and led by Manchester University, looked particularly at social prescribing in primary care networks and the roles of link workers, looking at the GP satisfaction survey. And again, this was over 4 million responses and showed measurable, meaningful improvements in patients' confidence managing long-term conditions, in how they feel supported by local services, and overall experience with general practice. We also have the national evaluation of the cross-government funded Preventing and Tackling Mental Ill Health through Green Social Prescribing project. Quite a mouthful. And this project brought together a number of partners to test whether nature-based social prescribing in particular, when integrated with NHS and mental health services, would lead to statistically significant improvements. And of course, what we see is that it did. There's a summary of the evidence, which you can find in detail, published by DEFRA, which showed that over 8,000 people engaged in this particular programme, and some really effective data showing both reach into socioeconomically deprived areas, but also improvements in well-being and depression symptoms. So, and also social return on investment and so financial value from these sorts of models. So we really have a great deal of evidence emerging in the last 6 to 12 months from a range of places that help us to build this picture that social prescribing is effective and it is cost effective, but there is still a lot to do because we're not able yet to track in detail much of the data. And that's why this partnership between the National Academy and University College London is really important, because what we aim to do is to produce more reports on the impact of social prescribing, but also to work strategically with partners in the research world, but also within NHS leadership and with government, to make sure that it is much easier to access the very best, most high quality and robust data to inform the government's shift to a more proactive and sustainable health service. So we're really at the start of this journey, but we've already made very significant progress. So I'm really delighted now to hand over to Professor Daisy Fancourt, who I would say is the world's leading researcher in social prescribing and creative health, for a really hugely insightful overview of the work of the Centre so far and of UCL. So thank you for listening, and I'll pass over to Daisy now.
Thank you so much, Charlotte. And it's really wonderful to be speaking to you all today about the work that we've been doing in the first 6 months as being the National Centre. I'm going to talk particularly about what we've done in those months, but I also want to contextualise this with what's been happening in the 6 months prior to that. So basically looking across the last year, because that really gives more of a context about what we were doing in the lead up to this designation from NASP as well. For those of you who don't know the work of me and my team, we are a research group at University College London called the Social Biobehavioural Research Group, and our work focuses on the impact of social connections and behaviours on our health. So that's everything from social deficits like loneliness and isolation to social assets, which include things like community engagement, leisure, arts and culture, social support, and of course mechanisms like social prescribing that help people to engage in those activities. We have 5 main programmes of work within the team, thinking about, we run lots of clinical trials and implementation science studies. We've got a major epidemiology strand using data from cohort studies and electronic patient records. We have particular specialism in psychobiological research and molecular biology, so trying to understand the underlying biological mechanisms that link these connections and behaviours to our health. We also do a lot of behavioural science, so trying to understand how people can change their behaviours. And we do lots of theory development using the lens of complexity science. So when we developed this partnership with NASP and this designation earlier this year, for us, it was really exciting because it actually built not only on the research that we'd already been doing, but also a lot of the partnerships that we've been cultivating over the last few years. So this includes the fact that we were already the host for the Social Prescribing Youth Network, which involves 1,300 stakeholders. And I'm going to talk a little bit more about that work later. We're also a WHO collaborating centre on arts and health. So we've been working with WHO for the past 8 years now, thinking about international policy that relates to arts and arts prescribing. And we also have an increasing partnership with UNESCO as well. But the designation as the National Centre for Social Prescribing Data and Analysis really brought a lot of these things together to think about how we can leverage those existing partnerships alongside the research that we're doing to hopefully have an impact in the UK on social prescribing delivery. So as you heard, we had 3 initial aims, which Charlotte put on her final slide, but this has, in the natural way of things, ballooned in the months since. So we're actually working on 9 different components at the moment, which I thought I'd just give you a little taster overview. It's going to have to be whistle stop given the amount of time that we have, but the slides will be available afterwards if people want to follow up on any of the references that I talk about or any of the studies in particular. So starting first of all with thinking about the impact of activities, even before social prescribing was such a big service in the UK, as a team, we looked a lot at how engagement in community activities influenced long-term health outcomes. So trying to quantify the effects of the activities themselves that are often the end point of social prescribing referrals. This is where a lot of our epidemiology work has come in. And while we've looked at this across lots of different kinds of behaviours, the one that we have done the most research on has been arts, culture and heritage engagements. So in fact, in 2023, we published a paper, a report that summarised our epidemiology work on arts and culture in relation to population health outcomes. And this summarised the findings from the first 70 studies that we'd published on this. This has now expanded since to well over 100 epidemiology papers that we've published. So it's been a really major programme of work. But just over a year ago, about a year and a half ago, we became aware of 2 main challenges with this. The first of all was that almost all of the research that we and others had also been doing has been coming from the UK and the US, which is really interesting when we're then thinking about social prescribing in the UK and the US. But there was very little that had come about from other countries. And as you can see on this slide, what we were seeing in particular was essentially high income Western global North countries that had this data. So this is one of the big things we became aware of as well. Do these kinds of community activities have benefits in other countries? And it's particularly pertinent as social prescribing is becoming more of a global phenomenon. The other thing we've been thinking about a lot was around statistical methods and causal inference, so how we can actually think about causality even when we're using these longitudinal data. And we've been doing a lot of the traditional methods like adjusting for people's demographics, their wealth, their other behaviours, but we started wanting to be more ambitious in what we were doing with that. So over the last year, 2 of the major developments that we've had has been expanding our work in epidemiology to consider more countries. This is a paper that we published in Nature Medicine just over a year ago, where we actually looked at the data from 16 different countries around the world, and we looked at how hobby engagement was related to subsequent mental and physical health outcomes. In this paper, we actually used 6 different statistical methods so that we were considering the strengths and weaknesses of each one and kind of balancing them out. And then we meta-analysed the findings for every country. This was a really exciting paper because actually what we found is that when we meta-analyse across all these different countries, we still see these overall effect sizes that having hobbies is related over time to lower depressive symptoms, better self-reported health, higher happiness and higher life satisfaction. So it's the first indication that we've ever had that these effects aren't just Western global North, but actually are found in some other contexts as well. Another major development in the last year has been on our methods work. We published a paper just a few months ago where we've been a lot more critical about where the challenges in epidemiological methods, looking at arts and also other community-based leisure programs are, but most crucially, how we can solve things. So we've actually put forward a number of recommendations in this paper for statistical methods in epidemiology, which includes alternative ways of thinking about confounders. It includes a new theoretical model that considers about what the factors that influence people's community and leisure engagement are, and how we need to take account of these richer factors rather than always just relying on things like education and wealth within our models. So we're hoping that this is a really good kind of foundational work for other people who might be working, looking at these cohort data and these observational data and thinking about these community-based activities. Another big development that we've been doing on this epidemiology work, which might initially sound quite far removed from thinking about social prescribing, but actually I think is really critical, is thinking more about these biological mechanisms that explain it. And the reason I think this is important is because when we talk about social prescribing, because it's social, I think it sometimes has a challenge in standing up against the more biomedical approaches that we have within healthcare, like pharmacological treatments. And I think it's very important that we're actually able to articulate how social interventions compare to those in terms of the biological processes that they affect. And we've actually have really excellent research on this for some types of interventions, like physical activity. There's a really strong biological literature now, which helps to make the case for why physical activity is so important as a health behaviour to think about in the context of the NHS. But we haven't really had this so much for some of the other behaviours, some of the things like arts and cultural engagement, for example. So we've also been seeing whether we can expand the evidence base for this, just to, again, strengthen those overall foundations relevant to social prescribing. We published a paper about a year and a half ago where we used international cohort data from thousands of people and looked at their patterns of engagement in all kinds of leisure activities in the community, which included sports groups, culture, heritage, archives, arts, volunteering, community organisations. And what we actually saw when we looked at a broad range of different biomarkers was that the people who were more engaged actually had better cardiovascular measures. They had lower blood pressure and heart rates. They had lower levels of inflammation in their immune system, which is linked to mental and physical health outcomes. They had better neuroendocrine profiles, so lower levels of sort of stress-related biomarkers. They had better metabolic biomarkers as well, so lower levels of fatty acids like triglycerides, and better hemoglobin and cholesterol levels. And they also had better anthropometric outcomes, like lower waist circumference and body mass index. What we've now done in the last year, literally in the last few months, is start expanding this into more other kinds of molecular biomarker data in cohorts. One of the things we've been looking at is how engagement with arts and culture affects hundreds of different proteins that people have in their bodies. And this is actually really insightful. This work is still underway, but we're actually discovering there are new protein pathways beyond the things like inflammation that we've thought about before that are actually really relevant here. So, for example, changes in the way that cell populations proliferate and the way that cells signal between each other as a result, or linked in with people's arts engagement. So this is one exciting step. The other exciting step we've been doing is testing the feasibility of looking at arts and cultural and leisure engagement in relation to people's rate of biological aging, which is very much the rage at the moment within molecular biology and omics researchers trying to understand how health behaviours affect rates of biological aging. We've done this in two ways. We've looked at indices that take account of multiple different clinical biomarkers that people have in their body. We've created indices that predict people's biological age based on these biomarkers and compared it to their chronological age and showed that people actually have a lower biological compared to chronological age if they're more engaged in activities like arts and culture. And then we've also looked at their epigenetics, so the pattern of gene expression that they have in their bodies, and shown that people who have higher levels of engagement in arts and culture and heritage activities, and also a higher diversity of engagements, they're involved in more activities, actually have patterns of DNA methylation that indicate that they are biologically younger. So this is really exciting in providing some of that foundational biological explanation about why some of these behaviours are so important and relevant to think about in the context of the NHS. One of the major developments that we've just had confirmed is that we've been successful in receiving a Wellcome Discovery Award, which is a £3.5 million award, which means over the next 7 years, we're going to be massively expanding both the global epidemiology, the methods-based work, and also the molecular biology of this. So we're hoping that this will support the underpinnings of all of the discussions that we have on things like social prescribing that are connecting people to these kinds of behaviours. But as well as that foundational work, one of the things we've been doing is much more applied and thinking, well, let's talk about social prescribing as this mechanism, as this service in its own right. And I know that over various webinars and discussions of many people, there have been these debates about whether social prescribing can actually reach the people who might need it the most. There have been lots of these blogs and opinion pieces about whether it actually might disproportionately reach people who already would have engaged in community activities, would have already known about community advice and support. So we've wanted to test this much more. Is this true, or actually can social prescribing reach people most in need and those who it was initially set up to target? When social prescribing first started, we were commissioned by NHS England to do a piece of work looking at data in northwest London, comparing people who'd had the referrals in the first year compared to people who hadn't. What we actually found was that people who'd had social prescribing referrals were more likely to live in deprived areas. They already made more use of health services, and they had more long-term conditions, which was promising because those are the very people that we were trying to target with the service. One of the exciting developments in the last year is that we've actually succeeded on getting questions on social prescribing into one of the UK cohort studies, which is called ELSA, the English Longitudinal Study of Ageing. This is really exciting because it's a representative cohort study, which looks at all adults over the age of 50 living in England. As you can see, we've ended up with quite rich questions about whether someone has been referred to any of the following activities over the past 2 years. ELSA has waves every single 2 years, which means we can actually look at how these patterns are changing over time. In our first analysis of this, we've actually already found hundreds of individuals who are saying that they have had these referrals. And interestingly, it's the same pattern. People who are on benefits or have the lowest levels of wealth have been the most likely to have those referrals, as well as people with depression, chronic pain, and also multiple long-term conditions. So again, further support that it is reaching people in need. As these data are being included in every wave, and as ELSA has extremely rich data on health service utilisation, clinical outcomes, and other behaviours, over time, we're going to be able to start seeing how people who say they've had referrals, whether they have different outcomes. So it's going to give us really important outcome data. And we've got the first analyses of this that we'll be doing in the new year, as we already have the first 2-year follow-up from this. Another big development has been trying to look at another way of capturing social prescribing referral rates and outcomes, which is using CPRD, which is an administrative data set that looks at GP referrals to any kinds of activities, prescriptions, etc. There are particular codes that GPs can enter each time they speak to somebody about social prescribing or refer them to it. And through this, we've been able to chart exactly what's happened with social prescribing referrals since the national rollout began in 2019. And we can see this really sharp rise in the use of these codes within people's medical records. One of the exciting things is you've actually found that in the first 4 years alone, so just up to the end of 2023, there were 9.5 million GP consultations on social prescribing and 5.5 million referrals. And this is actually massive news because the NHS target was that in that first 4 years, 900,000 people would be referred. And we saw 5.6 million referrals in that time. So 6 times as many as actually was initially predicted. This shows that social prescribing is a much bigger service than actually we'd previously recognised or potentially even realised, but also that the same amount of money had actually been reaching far many more people than the NHS had anticipated. We've also seen, interestingly, that when it first started, even before it was a national service, but the codes were starting to be used, but when the national rollout began, it wasn't reaching people from deprived backgrounds perhaps as much as we might have hoped. It was probably about 40% of people were from the bottom half of deprived areas in England. But actually, we're seeing that year on year, the service is reaching people from the more deprived areas, which are these more yellow boxes here. So that suggests that we're getting better and better at the implementation in reaching those people who, again, potentially might stand to benefit most. But of course, one of the challenges here is this only actually looks at referrals from GPs, and we know that social prescribing is a broader service than that. So something else that we've done is we've built a relationship with Access Elemental, which is the largest cloud-based platform, industry platform for capturing information on social prescribing. We formed this relationship a few years ago and started to get the data through at the start of 2024. And we published our first paper with them just at end of autumn last year. What we looked at here is we looked at data from 160,000 people who'd had a referral to social prescribing, not just through GPs, but through any means. Elemental software is used by voluntary and community organisations. It's used by social care, education. It can even track individual referrals. So it gives us a nice picture that we can complementarily look at with the GP data. Something that we saw here was, again, the same kind of pattern, that actually people from the most deprived areas are the ones who have been getting the most referrals, which again is really interesting data. The other thing that we were able to see from this was about 72 to 85% of referrals seem to be coming from medical routes, so primary or secondary care. The rest are coming from these non-medical routes. So medical routes are by far the most dominant source of social prescribing referrals in the UK, but the non-medical appear particularly important because actually from an equity perspective, we see that people from the most deprived areas, younger adults, men, and people from minority ethnic groups are most likely to refer through the non-medical routes. And I think this is really critical for us to be able to stress. We've also, for the first time, been able to understand the reasons that people are being referred in to social prescribing and the types of interventions they're receiving. And this suggests that mental health is by far the most dominant reason that people are getting these kinds of referrals. But it has also highlighted that only one in three referrals actually led to somebody receiving an intervention or activity. And I think this is important both in the way that we conceptualize social prescribing, but also potentially thinking about whether there are barriers here. For example, whether this is to do with lack of funding for the actual activities themselves. We've literally last week published a new paper using elemental data, which has taken a much bigger sample size because we've now had refreshed data available from elemental. But in this, we looked specifically at people who had a diagnosis of a long-term condition. And we were saying, well, we know this is one of the groups that gets referred quite a bit. What are the reasons for this? In this paper, we've been able to identify the reasons that people with various conditions like musculoskeletal conditions, COPD, diabetes, etc., we can see why they're being referred in, and we can see that it varies by condition. So, for example, for musculoskeletal conditions, pain management is the dominant reason. For diabetes, it's more about weight management and healthy eating. So we can start to understand these patterns and referral reasons much better. But we can also then start to see what are the prescriptions that people are receiving. So, for example, we can see that with diabetes, diet and nutrition referrals are very much the dominant type of intervention that people are getting, which links very much in with the referral reason. But we can see there are also discrepancies in this. So, for example, we see that people with a physical disability, mental health actually isn't one of the main reasons that people initially get referred through. They normally get referred through for things like weight management and healthy eating. But actually, mental health is something that is actually referred much more for people. So it's important for us to understand that when people meet with a link worker, when they start discussing their needs, actually more needs are likely coming up that can then be targeted by social prescribing that might not have been initially appreciated or thought about by a GP or whoever was making those referrals. We've also, in the paper on this that you can look at if you're interested, we've actually mapped how well this compares with people feeling that their needs were met. So we've been able to show which groups, which long-term condition groups are feeling their needs are being best met by social prescribing. And we hope this will support implementation and practice of delivering social prescribing referrals. We've also started working in the US thinking about social prescribing, which is a very different context because it doesn't yet have a national program, but it does have some pilots. One of the things that we've worked on with partners out there is a national survey asking if people would change their behaviour if they were given a social prescription. One of the things that's interesting here, in the first data we've had on this, is it's a representative sample of adults we've looked at, and we found there's actually very little variation based on things like wealth. You can see that the most wealthy people slightly thought they'd be more likely to take up the prescription, but there's very little difference between wealth here. And when we look at this in terms of what are the predictors of who says they would take up a prescription, there's not really any variation on education or wealth or demographics. Baby boomers are particularly keen, it seems, in terms of the age groups. The only real barrier has actually been that people in rural or suburban areas have been less likely to think they'd be less likely to take up a prescription compared to people in urban areas, which could be thinking about issues around access. But it actually shows that there seems to be quite broad considerations that social prescribing could change behaviours across all adults in the US, which is really exciting as they're starting to think about what national delivery might look like. One of the other things that we've been doing a lot of is leading clinical trials of social prescribing, and we're aware this is a type of evidence that gets called for a lot, but it's often one that's quite complex, expensive, and time-consuming to do. But nonetheless, we've been really lucky with funding on this to be able to have a number of quite large-scale clinical trials underway. One of them that we've worked on with colleagues in Greece has been looking specifically at arts-based prescribing for people with severe mental illness. So this first trial involved 400 adults in the community who had diagnoses of severe mental illness, who were asked if they wanted to take part in arts-based social prescribing. If they said yes, then they met with a kind of link worker equivalent, and there were 12 different activities they could choose to be referred to. So it was much more narrow than typical definitions of all social prescribing, but it was giving that element of choice and considerations about whether they wanted to go to museums or the cinema or theatre, or they wanted to take part in more participatory workshops. As you can see, our first trial has had really wonderful results, showing that the control care as usual group didn't really have any change, but those who took up the prescriptions had quite marked improvements in depression and anxiety symptoms. What we're now doing in Greece is actually a follow-on replication trial because the results were really good. We kind of want to be completely sure on this. So we've got another 400 to 500 adults, same population, now taking part, but this time expanding to more different urban areas around Greece, which is really nice to think about from an implementation perspective. This is really relevant because Greece is considering whether it might be able to do a more national rollout of social prescribing, arts-based prescribing particularly, within its mental health services, as well as other plans to think about the whole concept of social prescribing nationally. So this is a really exciting advance. And I think it has relevance for the UK as well, because we have same populations as severe mental illness, but often we know that they're the ones who are less engaged in social prescribing currently. We've also been working on a specific trial on singing for people with postnatal depression, which develops an intervention that the organisation Breathe Arts Health Research runs, which is a 10-week singing programme. This is a bespoke programme that's designed to meet the needs of women with postnatal depression, but it's something that people can be referred to through health visitors, through midwives, through GPs, psychiatrists, or community or social work referrals. We started running trials on this back in 2015, and our first trials show that those who took part in the singing intervention recovered a month earlier, either than those who had usual care or those who took part in kind of mum and baby play groups, suggesting that more bespoke intervention here was particularly valuable. We've now expanded this, asking the question of, does it matter if people take part in the bespoke workshop or are given the same kind of signposting and encouragement to go to existing community provision? And we've actually found that over 6 months of follow-up, the strongest results are those who are actually in the bespoke intervention. We've then actually, for the first time, calculated the health economics of this. So we've looked at what the improvements in quality adjusted life years are as a result of engagement in the intervention rather than just signposting. And we've calculated the total incremental cost of this, which is between £11,000 and £21,000. This is actually below, so in a good way, it's what the National Institute of Clinical Excellence asks for, to sort of consider things to be cost effective. And we found that it's got a very high probability of being cost effective in the NHS. We even compared it to what current offerings are available for postnatal depression and shown that it matches up really favourably. So this, I think, is also important to think about whether it's always the case that there's lots of participant choice, or whether there are certain populations where it's really important that they are actually given really well-matched interventions based on their particular clinical needs. And I think one of the arguments we're trying to make now, including with further funding that we're now applying for, is whether we can develop certain bespoke interventions like this further so that we've got very targeted offerings alongside any other kinds of social prescriptions that people with postnatal depression might receive. We also have a really major programme of children and young people trials, which is led by Dan Hayes with my team. We have several underway at the moment. One of these is called Inspire, and it's been delivering social prescribing in child and adolescent mental health services for young people on waiting lists. This has been a massive project involving 11 different CAMS sites across England, nearly 600 young people on waiting lists taking part in the control of the intervention group. We've already had some webinars and resources on this, like guides for how to set up social prescribing within CAMS services. And we've got actually some really exciting results from this that we're going to be sharing in a webinar next month from NASP. So I won't spoil the surprise yet, but we're going to be publishing all of these shortly as well. Another trial that we've have underway is then thinking about social prescribing more in kind of primary prevention. So working with 30 schools around England, looking at young people at the end of primary school and the start of secondary school who might already be showing symptoms of loneliness, and seeing whether social prescribing is an effective intervention to reduce those symptoms before they might develop into broader mental health problems. We completed our pilot study of this earlier in the year, which again has been really promising, showing very high feasibility and really promising results. And now we have the full trial, which is just starting up now, and we already have the first young people being recruited into social prescribing. And then our other larger trial at the moment is then thinking more about child and adolescent mental health services, but for young people when they finish treatment. So if they finish treatment after a brief psychological intervention, what then happens to them? We're saying, could social prescribing bridge the gap as they return to kind of normal life and community and help them to put into action tools and skills they might have developed as part of their psychological treatments? This is particularly working in Norfolk and Suffolk and North London, and this trial is just about to start recruiting as well. Another really interesting thing that we're looking at the moment is thinking more about the health economics of social prescribing. As Charlotte mentioned, there have been some wonderful reports from NASP that have already come out considering some of the effects on health service utilisation and sort of potential returns and social returns on investment. Lots of these have been have been looking at local evaluations, but there have been some larger ones coming up. The larger ones have tended to be looking at more specific types of social prescribing, like green social prescribing. So one of the things that we've looked to do this year is, can we get other large-scale data, but looking at the whole of social prescribing more broadly? We've started doing this in the Elemental data set that I mentioned earlier. So Elemental actually has pre-post measures embedded within it for some of the people who've taken part. So we've got a sample size of about 20,000 so far for these analyses. What we've looked at is the before and after measures of well-being using the Warwick-Edinburgh scale and also the ONS well-being measures. And we've actually seen quite clear improvements here just over the first couple of months after people initially get referred into social prescribing and start to have engagements with link workers and activities. What we've then done is, because the Treasury Green Book provides values of what certain improvements in life satisfaction in particular are worth from a health economics perspective. So we've then used these values that are attributed, and we've considered, well, what is this improvement in life satisfaction worth? We found that just in the first 2.5 months, this value is just over £4,000. And when we consider this relative to the NHS's estimates for what the costs of social prescribing are, we're finding that for well-being alone, this is coming out as a return of £9 for every pound that's spent. So this is really exciting to have this in a kind of large scale. But this is only really thinking about that well-being measure. One of the other things that we wanted to do is to think more about other kinds of returns on investment, and again, whether we can leverage large-scale data to think about this. So we published a report last Christmas with DCMS, where we tried to do this by using some of the same data, epidemiology data that I started off talking about in this presentation. So we were considering not only the improvements in well-being, but also reductions in health and social care data and improvements in productivity. What we found when we looked at arts and culture specifically is, if we look at the behaviours, arts and cultural engagement just from working age adults alone, we actually see that each year, just general engagement in arts and culture has an overall value of £18.6 billion to the UK economy. And we've calculated this more specifically for things like mental health, as well as the, certain conditions like dementia, for example. So this report is actually giving us, for the first time, a way of actually being able to value these patterns of engagement. This is outside of this social prescribing mechanism specifically, but it does help to make the case for why the mechanisms of social prescribing can be so important to get people to these activities. One of the other things we're doing now is a systematic review of the published and grey literature on the economic impact of social prescribing, which we're doing with colleagues in the US and in Manchester, which we're hoping will be completed early next year. And we're also doing more of a deep dive looking at health service utilisation, both in the CPRD GP records and also in elemental data, so that we can start to understand what the patterns of health service utilisation after social prescribing referrals are and how they compare to before and to people who don't get it. and start to attach some financial value to this as well. Another big focus has been thinking about enhancing data quality, because a lot of what I've spoken to you about is about what we're doing, making use of pre-existing data. So we need to make sure the data are good quality. We've analysed data in the last few months from the Social Prescribing Link Worker Survey that NASP runs, which it took over from the NHS last year. One of the concerning things we found in this is that actually 1 in 4 link workers say that they are never recording or monitoring patient impact or service impact of social prescribing. And this is a concern because actually the Social Prescribing Information Standard says that all link workers need to be reporting this, and we're seeing lots of people aren't. What's promising is we actually don't see any difference when we say what effects do you think it's having. We're not seeing any meaningful difference between what the ones who don't report and the ones who do report believe. So I don't believe that the missing data are giving a completely different picture, but it's still worth us considering how we can improve it. We've gathered some interesting data in this paper, such as seeing that ONS4 is the measure that people are using the most, which I think is helpful for anyone who wants to start reporting, is to sort of benchmark with the same measure. And we're seeing that people are mainly just reporting in electronic health records, although systems like Joy and Elemental are being used by some link workers as a way of capturing their pre-post outcome data. The other thing we've then done in this is said, well, how could we actually improve this? One of the big predictors of people bothering to report is actually feeling that this is being used to change investment decisions, and if there's someone who is asking to see this data. So I think this is really important when we're trying to think about motivating, is whether we can make it really clear the value of these data to supporting investment in social prescribing. And there's also been calls for things like some simpler processes and better integration with medical records to enable people to capture this more. Another project we're going to be doing then to try and support this is then to think about the way that social prescribing is coded, because when we see that feedback about needing simpler processes is there, something we know is a problem is there are so many codes that GPs can use for social prescribing. There are 16 that are specific to social prescribing, and then there are even more that cover things like particular types of social prescribing, like green social prescribing, creative social prescribing. So we've now got funding from Natural England and DEFRA to actually look within patient records at which of these codes are actually being used, which aren't. And we're going to be trying to work out if we can provide some streamlined guidance to people working in social prescribing to improve and simplify what needs to be captured. And to support all of this, we've been really lucky to have some data workshops that have been led by NASP, involving some amazing partners that have been coming together every few months to think about data and how we can enhance it. Another big focus has been in advancing policy. We've been working with NASP on their plans for a social prescribing fund in England. Part of this has been meeting and considering what a research and evaluation strategy for the fund could look like, but it's also been providing some really key reports, like demonstrating that social prescribing does reach people from most deprived backgrounds to help encourage policymakers in the space to acknowledge the value that this service is delivering. In the US, we've also been working quite a bit on plans for a kind of more national program. We led the evaluation of the pilot in the US, which involved 22 different social prescribing sites. And we published a report on this at the start of the year, as well as a piece in the Lancet Public Health, where we considered what the policy implications were. We've also started discussions with the Federal Reserve Bank in New York, and I went out and visited last month, and we spoke a lot about plans for health economic evaluations within the US, which of course have to look very different, given we've got a very different healthcare system there. And we're also supporting other social prescribing schemes. We're currently involved in projects with partners in 7 other countries, which is really exciting to see what we can learn from this international work and bring back into the UK as well. We've also been trying to advance practice, so consider what can we do to support people who are actually delivering social prescribing on the grounds. Because we're the Social Prescribing Youth Network, this has been our particular focus on children and young people. The Social Prescribing Youth Network actually started 7 years ago by Street Games and has built up an incredible momentum. We took over as the new hosts in 2024, and what we've now been doing is launching a new programme to support policy, practice and research. So for those of you who don't know about it, the Social Prescribing Youth Network, it's free, it's open to all. We have lots of different events and things people can get involved with. And we've got really diverse members, including link workers, commissioners, funders, policymakers, healthcare professionals and researchers. Some of the activities we've done just this year alone is that we secured some initial funding for this network to start activities up again. We've had some online meetups. We've been refreshing all the resources that are available on the website. We have a new youth advisory group of young people who've been helping us to think about what our priorities should be as a network. And we've had a particular focus on policy. So we've published a policy brief. We've held some policy roundtables. We've been trying to understand what best practice for youth social prescribing looks like. And we've got blogs and various other outputs from this that are coming out of this at the moment. This is going to be completed by early next year, when we'll be producing some best practice guidelines and also free online training for people who want to work in youth social prescribing. And we have a national policy stakeholder event at the South Bank Centre in February to launch all of these new resources. And then the final thing which we've been trying to do is sort of advance awareness more generally about social prescribing and the activities that underlie it. Personally, I've been working on a side project, which is a new book about arts, culture and health, which comes out in just a few weeks, which has been a lot of fun to write. It's a popular science book trying to promote the scientific evidence base around why arts and culture are so important to health and well-being, trying to position the arts as another health behaviour alongside physical activity, diet and sleep. So for those of you interested in this space, I hope that you'll find this a useful resource. But the final thing I really want to do is just to acknowledge the incredible team that we have here at UCL. I've described, as you can see, a huge amount of work, and it's a very much a team effort. So I just want to show all of the people who've been involved in this from the Social Biobehavioural Research Group. I also just want to acknowledge as well, in addition to our funding and support from the National Academy, we also have had support for this social prescribing work from lots of other funders who I think are really key to acknowledge here. And overall, we feel really excited by what is coming in terms of research. It feels like in the last year, there's been such an awareness and gathering momentum, particularly thinking about big data and how we can leverage these in large-scale trials to have a much stronger case for what social prescribing is and how it works. And we're really hoping that this will support all the incredible work of community organisations and healthcare providers who are actually delivering social prescribing, and hopefully support the continuation of this really rather remarkable service. So thank you very much, and I'm happy to take any questions as well.
Thank you, Daisy. That was amazing. There's so much research. You did yeah, an amazing job of getting through all of that in, I think we had about 40 minutes. And yeah, there's lots of comments about how insightful that's been and how useful for people's roles to have that kind of evidence base. And yeah, the new research coming out is exciting too. So we've had quite a few questions in the chat as well. There's one really key question, I think, I'll ask to both, I suppose, Daisy and Charlotte. So there's a danger that by the time evidence convinces central government and filters into commissioning and contractual mechanisms in primary care, that the widening of the R's role spec will have reduced the social prescribing link worker role, workforce, and that's been kind of seen late in kind of locally. So any kind of response or yeah, to how we can ensure that we do get kind of evidence out in time to kind of convince those kind of decision makers.
I think this is something that really worries me, because social prescribing, as we all know, kind of developed slightly cart before the horse, where we were getting a lot of investment and policy around it before there was actually the full evidence base to back that up. And so I feel like the evidence base has been trying to play catch up over the last few years with this, but perhaps not necessarily fast enough. Right now, I kind of wish that we were 2 years further down the line with evidence for the state of what's happening now with big policy decisions. I think there are so many people, not just us, but other research groups as well, that are working on like big studies and big data analysis and big trials. And I think that kind of evidence is the one that I keep hearing from policymakers is the type that they particularly feel the need for at the moment, those kind of big numbers that will help to explain the value of the service. And I know that there's a lot of that that's coming. So I think that's also kind of partly our responsibility as well as NASP's and how we're communicating that. And I think it's also really, from our perspective, helping us guide which research questions we're heading for first, because we're trying to go for those big hitters that we know are the ones that policymakers are asking for the most.
Charlotte, did you want to add?
Yeah, absolutely. I think it is a really key risk. And although we have the 10-year plan as those sort of high level ambitions, we aren't at the stage where there's really clear mechanisms, investment and support for what we need to do. But that's really been the main driver of this partnership work from NASP and UCL and our other academic partners. And we are working incredibly hard to showcase the evidence that's sort of flowing from Daisy and from our other partners and contacts, and we share it with Department of Health every single month. There was a meeting in Parliament yesterday, a Creative Health Parliamentary Roundtable. Baroness Merron, the Mental Health Minister, attended, and your work was mentioned, Daisy, by and others from King's College, because the first thing that she says is the evidence robust enough now for us to take this forward? And the voices in the room were incredibly strongly advocating that the evidence is there. Yes, there are gaps. Yes, we could know a bit more, but it is now incredibly robust. And she very much took that message away. What was really helpful is we also had the chief executive of an integrated care board at that meeting saying, yes, finances are really tight, but we really want to do this. And actually more leadership and direction from government and from the centre enables us to do this. So you even heard NHS commissioners agreeing with this. But obviously what we know is the incredible financial pressures on government and on the NHS. So all I can say is that I think it's up to all of us to be equipped with this evidence and to use it at local, regional and national level whenever we get the opportunity to influence policymakers, politicians, your local MP, and NASP will certainly be collating and convening and bringing together all this evidence for you on our website and through events like this, so that you are equipped to do some of that champion and campaigning. Thanks, Joelle.
Thank you. Yeah, and there was quite a few questions about data quality and recording. So asking about kind of how standardised the primary care data is, and there was a couple of comments about difficulties using ONS4 in EMIS systems and being able to kind of total it correctly. So thank you for highlighting that. I've already contacted our data specialist to look into that as well, and we'll be following that up. And someone's mentioned as well kind of the SNOMED codes and the information standards, but I don't know if you had anything else to say about how kind of improving the standardization of data so that this kind of big analysis is possible.
I think sometimes what seems to be coming up from the link workers survey and also some conversations that we've had with link workers around here is sometimes there can be this sort of overburden of needing to capture lots of things. And I think we need to be super clear about like what's the one thing that's the most important. The most important thing is that it is coded into records, because at least if it's coded, there are already naturally captured outcomes that we can look at, like health service utilization, for example. If it's coded and there's also some kind of outcome data like ONS4, for example, then that's a kind of bonus in terms of what we can look at. But I think data quality is a big issue. So for example, in the elemental data, one of the things that we see is only about 5% of people have got ethnicity data coded within it, which then really affects what we can then do when we're thinking about inequalities. So we're trying to make some clear recommendations through all of this work about what the minimum data capture is. I think we know, though, that there's a lot of pressure on organizations and that they don't want to feel like it's just more burden. So that's why I think we've spoken about minimum data sets in the past, but I think we need to be even more minimum, just to try and make sure that we've got like the foundations of what we need rather than expecting too much and getting nothing. I would also say I think there's a challenge. I saw some questions around where they can access data. There is a massive challenge around that. We're the only research group that we know of at the moment that has access to Access Elemental data, and because there's understandable challenges around industry partners being happy sharing data, which is completely natural. And even with CPRD data, like it's very lengthy processes, it's very expensive to access data, and then the coding required and the statistical work is phenomenally complex. So I think that these have been barriers in the past to having this, but there are now, a few teams that are working on this, and I think that's really promising to have that expertise being built up within the field.
Thank you, Daisy. And there are a few questions as well that came in initially around particularly kind of groups that are facing inequality, so people who are blind, partially sighted, or those with learning disabilities, and any particular research into kind of access to social prescribing and outcomes for those groups, how to ensure that social prescribing reaches those, and we have the data to...
Yeah, I'm conscious I've presented these kind of like high level figures that look at very large populations, but I think that's not to deprioritize how important it is to have more specific studies that look at particular populations, particular geographical areas, particular implementation challenges. I think that's actually something that's been really strong within the field of social prescribing. There's always been a lot of local work, a lot of local evaluations, a lot of patient-specific interventions. And I think that's something that we just have to make sure that we maintain alongside all of that. And of course, that's what we've been trying with the youth social prescribing in particular, is developing those pathways that might need to be more nuanced for young people and involve settings outside of GPs as well.
Thank you. I think there's still a few more questions, but we've only got a minute left, so we can cover them all. But thank you so much. We also, Daisy mentioned the other webinar that we have coming up on the Wellbeing While Waiting study for children and young people on CAMHS waiting list. So that's on the 11th of November. So do sign up for that. It'll be exciting to hear. The results will just be out for that. And then also we've updated our evidence pages on NASP as well. So do have a look on our website to see some of the latest kind of evidence that Charlotte presented. And thank you so much, Daisy and Charlotte, for preparing for all the research that you've shared today. It's been really interesting. I'm sure everyone will agree, and we'll send out the slides and the webinar recording will be sent out and on our website as well. So thank you everyone for joining and your engagement as well. Thank you very much.